that is okay too. And this is an opportunity to really understand the roles we're going to be talking about throughout the year when we think about integrated care team members in primary care. Just a couple quick, let's see here, reminders around Zoom. My understanding is that we are recording this session, and at the end, Marlena will tell you kind of how you can access the recording for team members who couldn't make it. All lines will be muted, or if they are not, there's a little phone at the bottom of your screen where you can click mute. There will be opportunities at different points in the presentation where we can unmute lines or people can chat in questions. There is a chat function, which many of you have found, which is great. To see so many people on the call today. So chat in your questions, and we'd ask you to try it out and chat in your name, organization, and role if you haven't had a chance to do that. Again, the recording and the slide handout will be available on the portal, and we'll go through how to access that after the webinar today. All right, so as I mentioned, we're really going to spend some time really going through the details around the different roles that when we talk about behavioral health and primary care. I'm going to first kind of go through hiring and staffing considerations when you think about that behavioral health provider role in primary care. And I'm going to ask all of you to kind of give me examples and tell me where you're at. We're going to talk about the different roles psychiatry providers play in integrated care and what those different options look like. And then we're also going to really focus in on that primary care provider role that's key on a collaborative care team. So those are the kind of the three main points I hope to hit today. All right, one moment. All right, so these are principles I think I've put up on the last webinar and during the kickoff that we're really going to drill down and talk a lot about over the coming months with all of your teams. So today, the focus is going to be on this first principle around team-based care. So primary care and behavioral health providers collaborating effectively and using shared care plans. We're going to really dive into what those roles are. In future webinars, we're going to be touching on more in-depthly on population-based care, using a caseload to drive treat to target, and thinking about measurement-based care. This quote around care team members comes from actually the BRE Collaborative. They came out in 2017 with the Behavioral Health Integration Report and recommendations, and they define kind of having an integrated care team as each member of that integrated care team has clearly defined roles for both physical and behavioral health services. And, you know, regardless of who your team members are, I think that's the critical piece here, is that really defining what those roles look like. And if you think back to that pyramid I showed you a couple weeks ago at that Learning Collaborative kickoff, really thinking about what those roles are in your stepped care strategy. And we'll talk about that later on in this webinar as well. As you're kind of, some of you in the early stages right now, thinking about your program and what those roles are going to look like, it's also a good time to be thinking about overall for your program and where you're headed. You know, what are your priorities and what is it that you want to see at the end of the day? What's the value add of your integrated care program? What are you looking at trying to achieve? Is it all about access? Is it about overall improving patient outcomes? Is it about, you know, care team, PCP satisfaction? What is it that's really driving this work? It's really important to step back as a team and say, before you kind of start that hiring process, and think about those team roles. And then you want to think about what are those tasks that are needed by those team members, and who do we currently have on the team, and what might be the added team members we're going to be bringing in, whether that be through a partnership with another agency, or maybe that is with hiring new team members onto a team. And then how are you going to, you know, successfully measure what you're doing? So if your value add is around access, you know, what is that going to look like, and how are you going to measure that? And then finally, how are you going to fund and sustain your program? And I put that up there, even though we're not going to focus too much today on funding and sustainability. As you think about who you're hiring, you're going to want to think about how you're going to be, you know, billing for services. Are you billing for services? And what can you bill for what types of staffing that you decide to bring onto your team? And we'll definitely have an opportunity at some point this winter, spring, to kind of tell you more about kind of funding and sustainability strategies. if your teams have questions in the meantime as you are thinking around about staffing, and myself are more than happy to answer those questions, because it does make a difference down the road if you want to think about billing fee for service or the collaborative care codes, or other codes that are out there, behavioral health integration codes, et cetera, and who can you hire to build those different codes. All right, so I showed you this triangle before. We're going to pretty specifically focus in on the two key, well, three. I'm going to focus a lot of time on the behavioral health provider role today, the psychiatric consultant role today, and then the critical piece around the primary care provider. I will try to do a little bit of, I'm going to do some comparing and contrasting though. While the focus is on the collaborative care team, I will do some comparing and contrasting kind of with other roles that you see out there and models that are out there. All right, so I talked a little bit about this at the last kickoff, but I want to reiterate it just because I think many of you are at different places right now and thinking through your team members in that role of that behavioral health provider. So the two kind of approaches that we see most commonly in primary care, one is the behavioral health consultant, primary care behavioral health role, which is really around immediate access of a behavioral health consultant. So often having very brief visits, very limited follow-up appointments, and being very available to that PCP team and to the patient. Sometimes measurement-based care can be part of that strategy, but not always. Sometimes it's more around immediate access to a behavioral health provider. In collaborative care, with the collaborative care model, it's really around having that behavioral health provider, again, be on that team, but following those patients until those patients get better, or maybe they need to be stepped up to care and that collaborative care episode is finished. So in addition, you're involving that psychiatric consultant on the team who's offering their expertise and reviewing cases with that behavioral health provider and offering recommendations to that primary care provider on any changes in medication or changes in their treatment. Again, in collaborative care, you can have brief visits, but you have brief visits and you have additional visits. So you might have one 30-minute visit. You might then have a quick phone call to that patient a few weeks later. You might then bring them back in for another 30-minute visit until they get better. And so it's really using measurement-based care and thinking about how can these patients get better. Oops, I heard someone cough. So just a reminder, just to mute your lines. All right, so we're going to dive into this kind of the right-hand side here today on collaborative care. If you still are kind of stuck on these models or what the differences are, you know, Ann and I again are really available to walk you through them. All right, so let's talk about this behavioral health provider role. The behavioral health provider role is working alongside that primary care team, really trying to engage that patient in care. They do that initial assessment and any additional follow-up visits and assessments that are needed. They are, most commonly we see them, and the research shows that, you know, being very available with warm handoffs, we also call that warm connections between the primary care provider and the behavioral health provider is really critical. We know that's a key thing with a behavioral health consultant. It's also something that's part of that behavioral health provider role under collaborative care. So being very available, whether that be through those warm connections, being interruptible as they can be in that primary care clinic. They're the ones though, so once that patient is engaged, they're the ones who initiate that treatment plan. They do the follow-up visits. They track the patients over time. So that's a big hallmark of collaborative care and measurement-based that we talk a lot about with that behavioral health provider, is that once they engage those patients in treatment, they're going to be entering those patients into a registry, a caseload type registry, which you'll hear more about in a few weeks, where they're tracking those patients. Who hasn't had a visit recently, who might be falling through the cracks? Who has a really high PHQ-9 score, or has been flagged for safety and they might need some additional support? Who do we need to keep an eye on? Who maybe is actually doing better and maybe it's time for less frequent touches with that patient? That's the purpose of using a registry in that behavioral health provider role. They also, the key piece is that it's not just them that's overseeing that treatment plan of that patient, but they're working very closely with that psychiatric consultant. So each week they're reviewing new patients who have come onto that caseload with that psychiatric consultant. they're looking at patients who are maybe not improving under the current treatment plan, who still have an elevated PHQ-9 score, for instance, or a GAD, and maybe a change needs to happen with their treatment, their medication. So that's a key piece of that behavioral health provider role. People sometimes ask us, and I think we have several behavioral health providers on today, you know, how do we know who to hire and who fits this role? One thing I'll say before I kind of go into, so these characteristics are really key. People ask us, well, should we hire a social worker? Should I hire a therapist, or should I hire a nurse? You know, being persistent, being flexible, being really comfortable with the fast-paced nature of primary care, I would say are really key things to look for in someone. You might be concerned about some of those other pieces around their credentialing. Again, if you're thinking about how you're going to fund your program and if you're going to bill for services. But key things to success are making sure that they like this team-based care environment, that they can be really flexible so that they can be interruptible, etc. So I think I mentioned a couple of these, being comfortable with, you know, higher volumes of patients, not just seeing patients in person, but also being amenable to wanting to follow up with a patient by a phone, or if that patient no-shows that day, you're doing a quick call to check in on them. Being able to be consulted frequently by the primary care provider, by other members of the team throughout the day. Oftentimes that could be in a crisis situation. Other times it could just be with a quick, I'm not sure what to do with this patient. Can you help kind of me figure out next steps, or if they are someone that you should see. I've seen too, in many instances, and this might be the case in some of your clinics too, where sometimes that behavioral health provider will help out the staff of that clinic and improve kind of overall employee wellness, overall kind of stress management strategies, a lunchtime workshop on that, et cetera, because they're the key person in that clinic that people come to for behavioral health. So key thing, frequent interruptions. I think I've talked about that too, but being amenable to that. So when you're hiring someone in this role, you know, thinking through, asking them questions around kind of what kind of environment they work best in and types of therapy that they enjoy doing. You don't want someone who's really passionate about those long-term relationships with their patients, because after about 6 months, sometimes it's less, sometimes it's a little bit more, usually those patients are taken to another level of care, moved back to their primary care provider. So you want someone who's able to see that patient for some quicker visits. Being able to assess quickly, make decisions is really important. Being able to, again, work with the fluctuations of a primary care fast-paced clinic, that kind of whoever comes in today, and we're going to kind of meet their needs. So things to be thinking about for many of you who are in this position right now where you're looking to hire, or maybe you're interviewing your behavioral health provider who's going to be on your team. All right. So people ask us too around kind of split duties and what do you do when you have maybe different people on our team that could perform these tasks. I know for those of you who are participating this year in the Learning Collaborative, some of you are hiring new staff. Some of you are kind of redeploying or retraining some existing staff. And some of you are collaborating. There's some great partnerships happening with behavioral health agency, and I see a couple that are on the call today. So spending some time thinking about whose role this is going to be is really important. And we work with teams, you know, where maybe there's a psychologist and a nurse, and they try to split up those duties. I would say there should still be kind of one main owner of that caseload, of those patients that are being managed. There might be someone helping. Sometimes we've seen a medical assistant help support that behavioral health provider, or maybe we've seen a model where there's both a behavioral health consultant, someone who's more accessible at all times to that primary care team, while someone else is doing more appointments and providing treatment. That can work too. You can have both collaborative care and a behavioral health consultant kind of model going too. But the key is that you really want to think about kind of one person who's really going to own this caseload and really be able to do good measurement-based care and get patients better. And whose job is that? If it's divided up into lots of different roles and everyone has a little task in it, things are get blurry, and really the kind of I am a prize and the focus of collaborative care, I think, is going to get lost. And we can talk more about that in some of the discussion. And Anne, I know, would probably have some thoughts on that too. But I like this. This is a real job. This is not just someone who's entering data into a caseload and is maybe just going to track those patients and follow up every now and then by phone. This is someone who's really going to take ownership of that caseload and say, hey, this person, Mr. Smith, is not getting better, and I need to review them tomorrow during my case review with the psychiatric consultant, and then get a recommendation back to the PCP, or maybe I need to change the psychotherapy that I'm providing to that patient to get them better. So something really to consider. Other considerations as you are hiring your team or staffing your team, and some of you maybe are in this space right now, is training programs for staff. Well, luckily you have this great training program coming from your ACH, but think about too how you're going to maintain that training moving forward, and we'll talk about that more throughout the year, and how you're going to onboard new clinics, etc. Clinical supervision. So especially if you're using unlicensed staff, thinking through, who's going to be that person on your team that can review cases with the behavioral health provider, who's going to provide that clinical supervision, which particularly if you're a primary care clinic, you might not have someone readily available to provide that clinical supervision, although many of you I know in these partnerships can kind of think that through. Something to consider early on, though. Credentialing process, I think you heard that from St. Luke's team a few weeks ago. They got stuck. They hired, and then they realized, wait, we never had credentialed our behavioral health providers under primary care before, and it took them a couple more months before they actually could start. So early on, just being aware that, and if you're going to be billing for services, that credentialing process can take some time. Setting up space so they have some space available to meet with their patients. That's a private space that's out of the main triage huddle area in your clinic. That's an actually kind of separate space. Thinking through early on to kind of how you're going to build out the templates for your behavioral health provider in EHR, how they're going to chart those notes, etc. Those are all kind of considerations. All right, I'm going to pause now. And I know we have some really experienced teams and others who might have questions. Whoops. So why do you guys think, or maybe for some of you who work in primary care right now, why do you like working in primary care? Could you either chat it in or maybe unmute your line for those behavioral health providers on the phone or those who work with behavioral health providers? Why work in primary care? Anyone? Anyone out there? Oh my God. Working with the whole person. Ooh, that's a great answer. I like that.
I can
You're not just.
Oh.
Yeah, go ahead.
My name's Kelly. I'm from Comprehensive Life Resources, and I'm not currently working in primary care. I'm working at a mental health agency, but I can tell you a huge percentage of the clients that we see who have more chronic and severe mental illnesses also have, multiple and complex medical problems, and getting the medical care and mental health care conjointly is often an issue. So I'm super excited to be located now in a primary care facility. I think it's going to be really good partnership.
Great. I love that idea, breaking down those silos and treating the whole person. Good. Other ideas or other thoughts that brought behavioral health providers into primary care? Engaging patients that would not have access to behavioral health through specialty care. Good. Great. Close to half of people who attempt suicide visited their PCP within 1 month of the attempt. It's important for us to be in primary care. Yeah, that you're really filling this gap and this need in primary care for sure, and to help your team members. Good. Anything else? All right. Maybe someone else. Every day it brings something different. The fast-paced collaborative interaction, for sure. We often have heard, I heard when I was hiring behavioral health providers, often like social workers who maybe had worked in a hospital setting or were used to fast-paced work, thinking on their feet. They loved working in primary care. Those who really liked that team where you could, run an idea by that psychiatric consultant, and you could work it with your primary care provider. That team atmosphere was really key. Close coordination and treatment planning between the primary care provider and behavioral health provider. Great. How about anyone with experience in hiring a behavioral health provider to work in primary care? Tips and tricks for your colleagues out there? No one? Maybe thinking about it? Huh. All right, thanks. Anyone out there? All right. We will provide on the portal, just so everyone knows later on, a job description. It's for that behavioral health provider in collaborative care role, care manager as we call it on our website. But that is available to you. And as we work one-on-one with your teams, if you need some help with like questions to ask during the hiring interview process, that kind of thing, we can be helpful with that. We have some tools around that. All right, I'm going to move on then. All right, so we're going to talk now a little bit around this psychiatric consultant role, which is that additional team member that we're really bringing to that primary care team under collaborative care. I think before I do that, though, I kind of want to talk through kind of different approaches to accessing psychiatric services, just so we can kind of compare and contrast them and you understand kind of what that psychiatric consultant role with collaborative care is about. So, on the one hand, we have like kind of traditional consultation with a psychiatric provider where that patient gets referred maybe out and to see someone in a behavioral health clinic. That might be a one-time consult. They might then assume the management with that behavioral health team, and under that behavioral health home, it's usually away from primary care. So that's that consultative approach. Co-located. So I know many of your clinics right now maybe you have psychiatric nurse practitioners who are embedded in primary care. They maybe have a day or two a week or a full schedule during the week where they have appointments to see patients. There's often really great communication coordination with primary care, but sometimes the access issue is still not addressed. And then with collaborative care, it's really about spreading that psychiatric provider across a larger population of primary care patients and working closely with that primary care team in that capacity. And I'll talk about that in a couple minutes here. So again, some of the challenges I think with traditional consultation, while definitely needed for working with patients at SMI who needed a consult to be seen, challenges around access, which I know your region faces and everywhere across the country they do. Sometimes feedback back to primary care can be a challenge, not always. I feel like we've done a lot of work on closing loops around referrals, but feedback can be limited, can be expensive. And sometimes it's just maybe a one-time thing, but additional consultation. A medication's changed, and I want an additional kind of consult from a psychiatric provider. That might not happen in traditional consultation. All right, so co-location. So in some collaborative care programs too, we see a psychiatric provider embedded within primary care where they maybe have some appointments. They might have, there's so many different ways people are using technology with e-consults or just, emailing with their psychiatric provider to get quick consults that way. Some of the challenges of just co-locating a psychiatric provider, again, is sometimes access can still be a problem depending on how you set up those schedules. Thinking about what's the follow-up and how is a co-located psychiatric provider's recommendations then used can also be something to think about. So when you think about the psychiatric consultant role in collaborative care, and I think we have a couple, maybe psych consultants on the call today, they're the ones who are really going to help drive that case review process. So it's really about spreading that psychiatric provider across a larger group of patients, because they can look at that caseload of that behavioral health provider. They're going to be looking at, 60, 70 patients once you get a really established caseload up and running, and it varies by site. And they're going to be looking at those who have been flagged. Maybe they're new to the caseload. Maybe they're patients who are not improving. Maybe they're patients that are ready for discharge, and the behavioral health provider just wants to run through what's happening with that patient. So that's a key piece of that psychiatric consultant role, and the key piece of collaborative care is that caseload review process. So that's the biggest kind of piece of with collaborative care and the psych consultant role. The other piece, though, I would say, and all of our trainers who are psychiatric providers really hit home and talk a lot about this. So you hear about this a lot this year, is being still available to consult with that primary care provider and team. So we'll be talking individually to each of your teams, to make sure you get not only set up that caseload review process, but how is that psychiatric consultant going to also be communicating to that primary care team? Maybe sometimes people will say they'll give out their cell number, or maybe they are available through some sort of electronic email through your EHR. Maybe they come routinely to like a lunchtime meeting and talk about complex patients that are being seen on the caseload and patterns that they're noticing in prescribing. So it's not just the caseload is key, but also having this availability, and thinking of a psychiatric consultant as not someone that is really remote and distant, but also part of your team is really important. I really like this image, and especially as teams are struggling with like, what's the benefit and why do this versus just co-locate a psychiatric provider if you have the ability to do that, it's really about leveraging a resource across the population. So you can see here in this image, where 8 hours in a week, you're consulting on up to 200 or so patients potentially, by quickly reviewing them with your, and you're not reviewing all of them, you're reviewing those that the behavioral health provider has determined that they need a review. But it's about spreading this resource across a larger number of patients. All right, similar to what we talked about earlier with behavioral health providers, psychiatric providers too, not everyone wants to do this work. So as you're looking at who you're going to have be in the psychiatric consultant role, again, thinking of someone who's really flexible, adaptable, likes to teach, I think is really important. The first time I saw a case review happen and sat in on one, I thought it reminded me a lot of kind of the relationship that preceptors have when they're teaching residents and offering kind of their kind of advice, et cetera, and recommendations. And so someone who likes to teach and offer their expertise back to a team, they're not only kind of giving those recommendations, to that behavioral health provider as far as the change in treatment, but it's really they're giving those recommendations back to that primary care provider as far as that medication recommendation. So someone who doesn't just maybe prescribe it, but also says why, and can take that back to like a lunch meeting or something to help educate the primary care team. Being willing to be a leader. I think I saw that one of the psych nurse practitioners who I met a few weeks ago for Tacoma CHC, she's been going through the integrated care training program where we've been training psychiatric providers around the state in this role. And we really see these psychiatric providers that we're training around the state and what we're doing this year in this program and being leaders and helping drive improvements in patient outcomes and in these behavioral health measures. So these are just some things to be thinking about with your psychiatric providers, as so many of you already know who that is, but if you don't yet, to consider if you can, when you're looking to fill this role. All right, let's talk about the key role of the primary care provider, specifically to collaborative care. And so, but first I'll say, with any kind of approach to integrating behavioral health and primary care, they're the one who, are identifying the patient. They might have already prescribed a medication. They might have been struggling with that diagnosis, and they're linking that patient to that behavioral health team. And so as we work with your primary care providers and your teams, we'll be talking about how do you introduce that behavioral health provider, because that's really key through those warm handoffs, through other ways of maybe other care team members also introducing that behavioral health provider. But the primary care provider has that already established relationship, right, with that patient. And so they're really offering the recommendation that, hey, I have another team member, this behavioral health provider on my team now that's going to be part of my team and helping treat you and getting you better. The primary care provider with collaborative care is the one who prescribes still the medication, right? So the psychiatric consultant offers the recommendation based on that caseload review process. Those recommendations are charted and noted in the EHR, sent over to the primary care provider, and they're the ones to act on it, whether they want to accept those recommendations or further discuss them, et cetera, et cetera. The behavioral health provider and the primary care provider often will have other ways that they maybe huddle, like maybe during the morning huddle to identify, hey, we've talked about these patients this last week, and these are the recommendations that have come from the psych consultant. We'll talk further about some of those kind of different communication ways you can communicate with primary care providers. The primary care provider in turn should also be allowed to, not to identify patients and say, hey, I would really love this patient to hear what the psychiatric consultant would have to say about this patient I've really been struggling with. They've been on SSRI for a while and things are not improving. So key with early engagement of those patients and getting them to that behavioral health provider, and then working with that collaborative care team on that treatment plan, and stepping up or down medications, et cetera. All right. Let's see, I have a couple other questions I wanted to ask all of you. I guess I'm curious about what you're doing with your program right now to help increase access to psychiatry services. How are you incorporating psychiatry into your practice? Could you just speak up or chat it in? I'd love to hear where we're at right now. Anyone out there? Biggest specialty care challenge we have in Pierce? Yes, it's everywhere. What are you doing to address it, I guess I might ask? Do we have anyone on the call who is in a psychiatric consultant role? Let's see. Telemedicine services a couple times. Yeah, so that's the common approach, I think, for access issues. I think the key thing there is consistency of providers, right, with some of the services. Okay, so you're trying different ways to do a consultation. E-consult through the care manager, a text, etc. Any way possible. Right. Being creative and how to get that expert advice. Other ideas out there? How are you using psychiatry right now? You're all struggling with it, I'm sure. Thanks, Claire. The psych nurse practitioner spends a day per week at the medical clinic for consultations. Can you tell us a little bit more about how those consultations are set up? You can chat it in, is fine. All right. She's doing that maybe. How about primary care providers? I think we have a couple on the call. And how are you going to engage your colleagues in this work and in this model? What plans do your clinics have, or ideas, thoughts to share about that? Anyone? I know one of the clinics is going to do a lunchtime introduction of collaborative care coming up for their primary care providers to introduce them to the model and what's to come. Others out there? You know, a few tips from my experience and from working with a lot of systems around the country. You know, as you hire that behavioral health provider and identifying that psychiatric consultant, having them be part of primary care provider meetings when they can be. Just getting really comfortable with them being seen as kind of another member of the team and a colleague is really important. Finding a champion. I think many of you have identified already your primary care champion. Early on, as you start to build your caseloads and as you start to think through your communication processes, how patients are going to move from primary care provider to the behavioral health provider, and then how communication is going to go back to primary care provider, having a pilot team to test out some of those approaches is really important. And then that PCP champion can kind of share that with other members of the primary care team. Hey, I had this difficult patient that I was struggling with, and the behavioral health provider helped me with it. And now I know kind of the next steps in their treatment, and can share kind of those case examples is always really great. In a single provider clinic, we plan on looking at our patient load to identify patients that have behavioral, linking them with a case manager to help with care resources. Okay, and then, looking at your patient load, like, so early on, so this might be somewhat you mean. So sometimes, often a PCP can recite, like, maybe there's 5 patients that they just know for sure, oh my gosh, I have a behavioral health provider now on my team. I can't wait for them to see that behavioral health provider. So that's like an easy way to early on identify patients, right? Also doing queries of just like we have many clinics when they're starting out, they'll look at patients who by diagnosis or medication history or that kind of thing to help identify patients on PCP panels early on that are great patients to refer to the behavioral health provider. Great. Anyone else? All right, let's move on. All right, so this is kind of a busy slide, but not to forget, I really wanted to hone in today so everyone understood the role of the psychiatric consultant, behavioral health provider, and the PCP. But it's really critical as you're building your team that you're informing, educating, and the rest of your team members that are in primary care. Often that MA is the one maybe who's assisting with that warm handoff to that behavioral health provider. The front desk is going to be involved in many of your clinics is already involved in maybe your screening process and handing out the PHQ-9 to the patient. Really making sure your clinic managers and your operations staff understand what this team is all about and kind of things to be thinking about operationally around space, around their schedule, around how that communication is going to flow between the behavioral health provider, the psych consultant, and then back to the primary care team. I would encourage you to, many of you, all of you have been working on patient-centered medical home and advanced care teams. You have some really great other team members like pharmacists or dietitians or educators who maybe also are identifying patients with behavioral health needs. So as you start to your program, how are they going to be referring patients and encouraging patients and working together as a team? And maybe you're going to kind of co-manage some of your patients together too. So just to consider and remember. All right, so this was that step strategy I showed you a couple weeks ago. And I just want to reiterate it again as you're thinking through your strategy, that it could be multi-layered. with some of these partnerships that are happening, it's not all going to be in primary care, and there's some patients are going to be managed by that primary care team, and you're going to staff appropriate for that primary care team, and then you're really going to be thinking about that relationship that you're making with specialty behavioral health, and how communication then comes back to primary care and vice versa. So which will be fun to do with all your teams. All right, that was the most bulk of my content today. Let me see. We have a little bit of a poll, but I can pull up there to see how we're doing today. But I really wanted to see what questions your teams have, because I know Marilena has been asked a couple questions around staffing, and there have been other questions floated out there as you're thinking about your team. So I wanted to allow time for you all to ask your questions today. So if you haven't done this before, it's just a click through. You'll get a poll that pops up on your screen, and there's 4 questions, and you go through them on the right-hand side to just tell us how we're doing and if we hit the mark today on the webinar today. While you're doing that, I just wanted to let you know a couple of resources. So we'll go ahead and post 2 job descriptions. I told you about the behavioral health provider job description. We also have one for a psychiatric consultant if you're still looking to hire. We have a tool as well called Core Tasks for behavioral health integration in primary care. It goes through lots of the tasks that happen on an integrated care team, and then it asks you to identify who's doing what, particularly if you do have multiple team members, or maybe even specialty behavioral health is going to be doing some of the work and primary care is going to be the other part. It helps you identify who's doing what on the team and if there are gaps. So we'll get that posted as well as a resource for today. Let's see here. All right, so I'm going to open it up now. And Marilyn, I know you wanted to talk a little bit about the portal as well. But if there are questions as you're thinking about hiring and staffing. There's a pretty quiet bunch. You can put them in the chat. If this left you more puzzled than not, I want to hear from you and tell me where you're at. Yeah, what type of liability concerns should consultants be able to manage? We have some, and we can post this too. We have some information around liability on our website. Making sure that they have documented their recommendations is really important, and those recommendations get back to the PCP is really important too. So thinking through how that's going to happen in the system, that those recommendations aren't just given verbally, but they're also documented is really important. I'm wondering what other questions, making sure, so also credentialing your psychiatric consultant. Some of you will be using someone internal, but others of you might be, I don't know, using someone in a different state, let's say, or something like that. That happens with that role. So going through that credentialing process. What specific liability questions maybe do you have? Ooh, someone can share a blurb with you that I utilize to clarify I have not seen the client but only done a chart review.
This is Ginny.
Yeah, thank you, Ginny.
I'm a psychiatric nurse practitioner at Community Health Care, and I just wanted to chime in. I'm the one that said that about the blurb. I know because I've been taking part in the fellowship this past year through the AIMS Center, there's been a lot of discussion around liability for psychiatric providers and sort of how do you hold that when you're not actually evaluating the client face-to-face. So that's one of the things that they've discussed in the fellowship is sort of crafting a statement that makes it clear in the written chart note that you haven't seen the client face-to-face. So if that's helpful at all, I can share those written words if anyone would like.
Yes, that would be fabulous. Marilena, is there a way to post that or get that to people?
Yeah, we would post it in the same space that we will be posting the post webinar materials on the WA portal.
Okay. So go ahead and send that to Marilena, and then I'll and I'll send
send it directly.
I will send that to Marilena.
Yep, and I'll send it to the link. We'll post it where we'll put the link about liability too on our website. Oh gosh, the average cost for paying a consultant psychiatrist. I don't know. Anne, are you on? You might know that one. You're working through some of our contracts. I don't know if you have any recommendations.
Hi, this is Anne. On the average cost question?
Yeah.
Yeah, I'm sorry, we don't really. I do know that there's a wide range of costs, and there's some different models of approaching this. Obviously, a psychiatric nurse practitioner is often a cheaper option and might be easier to find than a psychiatrist, for example. And sometimes our behavioral health organizations can support psych NPs with psychiatry backup and support for very complex patients if that's useful. So I'm sorry, there's no really one. I do know there is average salary information posted nationally because we've looked at that from time to time trying to gauge costs of care using a collaborative care model. So no really good easy answers for this one.
Yeah, there was a question around the roles. This is a good one around the roles between a nurse care manager being the behavioral provider versus a licensed mental health provider. Well, so yes, we've definitely seen nurses be in this care manager behavioral health provider role, treating them, in some of the evidence-based psychotherapy. Short-term evidence-based is kind of the one main thing that is a big training, something that they don't learn necessarily in school, right? And so it's one of those things that they have to get through training. You'll be getting that this year through our training programs. In addition, there's training on problem-solving treatment that's available on our website you can look at, et cetera. Some of that has to do with reimbursement strategies. So with a licensed mental health provider, you're able to, then reimburse for those fee-for-service psychotherapy codes. With an RN care manager, while you can't do the psychotherapy codes, you can submit for the collaborative care codes under Medicaid and Medicare, which we can dive into at some point. Nurses are really equipped to some of the kind of benefits with the nurses that they are, they often know how to use data. Maybe they've used data for physical health metrics, like looking quickly at blood pressure, BMI, things like that. So getting used to using a registry and tracking patients comes a little maybe naturally to them, being used to that fast-paced environment, being part of the team, et cetera, for those things. The pieces around the psychotherapy piece is generally the piece that maybe needs a little bit more training. But vice versa, licensed mental health provider, for them, it might, getting accustomed to working in a primary care culture, it might take more time, and getting used to using data and measurement-based treat to target, et cetera, might be different.
Sarah, this is Anne again.
Yeah, go for it. You might have some ideas too. Yeah.
I'll add my 2 cents. I am a nurse by training, and working with different organizations over the years, one of the things I suggest you do is consider all the needs of your patient population that you're going to be serving. For example, if you have a large number of patients who are diabetic, older, and you're already using nurses in roles as diabetes educators, then training your diabetes educator nurse in depression care is a great strategy. Your patients, it's a great experience for your patients because they've really got one care manager working with them across all their needs. So think about those kinds of patient needs that you're also having to manage and respond to. And that will help you think about where a nurse might be a best fit versus a licensed social worker. We work with a number of larger organizations that use both behavioral health clinicians and nurses in the role, depending on workforce availability and the largest patient populations in particular clinics in those organizations. So it's not an either-or decision. In fact, we're training our first nurses at UW Medicine end of this month in our OB clinics to be working with moms who are high risk for depression in our perinatal programs.
More questions, I think, around kind of the liability concerns, primary care. We will post those resources. Anne, I don't know if there's anything else you want to add to from your experience.
Well, I would just, I'm looking at the comment about the concern from a primary care standpoint. Yes, you are prescribing those medications. In truth, you are already responsible and liable for that patient with or without the psychiatric consultation and the additional support for your patients from the care manager. So that's really where liability rests. That's just another way to think about it. Having a stronger team, having frequent, reliable access for psychiatric consultation to help guide you, puts you in a better position and certainly helps your patient, likely to help your patient get better faster. But liability does always rest in primary care in this situation. And Sarah, there's a number of papers around liability and white papers, and we'll be sure and get those available to everybody who's on the call today. Thanks.
Yeah, definitely. Thanks. All right. Any other questions out there? These have been good ones. Thank you. Marlene, do you want to mention a little bit about the portal or anything while we're wrapping things up here?
Yeah, this is Marilena. I just wanted to also stop and thank Sarah and the AIMS Center for hosting today's webinar. It was really helpful content to kick off our next journey down the collaborative care model. So as next steps, I want to remind and call out that we will be sending out a follow-up email with this content, both the slides and the job descriptions attached, but we are trying to slowly herd and shepherd people over to the WA portal where we will be housing and saving all of this information. We do recognize that logging on and getting access to the WA portal can be somewhat of a tricky first go at it. So in these initial webinars, we will be following up with attachments, but as I mentioned, slowly migrating all materials over to WA portal. And instructions for how to log in to WA portal and register yourself will go out with this follow-up email as well. And then I wanted to call out that February is an uncommon month in 2019 in that we will be having 2 webinars. We have another one coming up on February 26th at the lunch hour again. And moving forward, we intend to have the last Tuesday held for webinars, 1 webinar a month, but we did want to squeeze in a little bit more content in the month of February. So please note that we will be still holding February 26th for the lunch hour webinar. And if you have any questions or any content that you would like reviewed and potentially saved to the webinar as a resource, or saved to the WA portal as a resource for the teams to review, please share with myself or Michelle, and our contact will be in the follow-up email as well.
Great. Thanks, everyone. Please bring to our next webinar in 2 weeks questions you have around using a registry for caseload management. We're going to dive more into measurement-based care and use of a registry because many of you are kind of trying to figure out which registry option to choose and make those decisions. So that will be the focus next time in 2 weeks. But in the meantime, I know Ann and I are trying to get out to visit many of you and get calls or site visits scheduled to get to know all of your teams more, and keep your questions coming to us. That's why we're here and available for these great questions. So, all right, have a great afternoon. Stay warm, everyone, and hope everyone's finally digging out of the snow a little bit, or now the flood, I guess. So, talk to everyone later. Bye.